to India Science. Namaste, all viewers. Today we are joined in FAQ by none other than D Nageshwar Reddy, who's the chairman, Asian Institute of Gastroenterology and AIG Hospitals. He's also the first Indian to have received the Rudolf Schindler Award, which is given to someone whose accomplishments in endoscopic research, training, and service exemplify the highest international standards. Thank you so much for joining us at India Science, sir. Our pleasure that you have taken out your time to be with us today. My first question to you, sir: how do you see the second wave rolling out now? Is it plateauing, sir?
Thank you, Nidhi. Thank you very much for giving me this opportunity to be in your, I think, very well organized shows. I think the second wave is flattening out now. As you can see, the statistics, we reached a peak of about 4 lakhs per day. Now we are coming down to less than 2 lakhs a day. Certainly, we can see this reflected in the hospital admissions and, of course, the outpatients that we're seeing. It's not reflected very much in the death rates because this is going to take. Normally, what happens is first the wave plateaus and then the death rates comes on. This is what happens all over the world.
Absolutely, sir. We hope to see the death rates also going down soon. But my first question again to you on the wave is that as we talk today, people are talking a lot about antibodies. Could you explain the process how antibodies are formed and what is that new technology in antibodies that is so much being talked about now?
Yeah. That's a very important question, Nidhi. We all know that whenever a bacteria or virus enters our body, it's a foreign subject. And when it enters our body, the body reacts by producing its army. The body's army is actually the antibodies. These antibodies come in large numbers. They go and attack the virus or the bacteria. They will actually neutralize this enemy, and then there are certain cells in the body called the phagocytes which go and eat up this enemy. So that's how body defends against itself, against any foreign invader, just like the army would do. So now in COVID-19, for example, against the SARS-CoV-2, also antibodies are produced. The unique thing about these antibodies are that for each different virus, there's a different set of antibodies. So if you have antibodies against, say, one type of virus, it's not effective against this type of virus. And because SARS-CoV-2, the virus, the COVID-19 virus, came into human beings for the first time, we never had any original antibodies against it. We just started developing it now. And these antibodies are now starting to come once the infection is going around the world. And till we reach a certain level of antibody, for example, if 70% of the population develops antibodies, then we develop what is called the herd immunity. Till that time, of course, the infection can spread from person to person. One of the ways of treating this is to give artificial antibodies. So how do we give artificial antibodies? We can take plasma from those patients who have recovered. It's called the convalescence plasma, which contains high antibody levels against this virus. So 4 weeks after they have recovered from the infection, we take this plasma and we give it to the patient. Now, the problem with this is the amount of antibodies is very diluted. There's only a certain amount of antibodies in plasma. 200 ml of plasma may contain a small amount of antibodies. To overcome this, one of the things to do was, and what science has done is, that they produced a high concentration of antibodies specifically against this virus. These are called monoclonal antibodies. They're produced from one clone of cells called the B cells. So the body has 2 types of lymphocytes, the B lymphocytes and the T lymphocytes. The B lymphocytes are the ones which produce the antibodies, and the T lymphocytes are the ones which give cell-mediated immunity. So once the antibodies neutralize the virus, the T cells attack. So the B cells which produce the antibodies, you can actually now take these B cells and put them into cultures and produce large amount of specific antibodies against this virus. And this has been done, and this has come out in monoclonal antibodies. There were 2 companies in US, the Roche company and Eli Lilly company, which made these monoclonal antibodies against this virus. And one of the most important developments that as they were developing these monoclonal antibodies, they found that if a single set of monoclonal antibodies was developed, this virus is very clever. It can change its shape and evade these monoclonal antibodies. Because basically what happens is, these antibodies go and stick to a part of virus called spike protein. And spike protein is the place where the virus comes and attaches to the body. So because the antibody is there, the spike protein cannot attach to the body. So what these companies did is, for having one monoclonal antibody, they had two monoclonal antibodies because the two areas the spike protein is attacked. So even if one area is not functioning, the other area is affected. So these monoclonal antibodies are always given as antibodies cocktail. Two separate antibodies are given. They've got a complicated name, but they're two different antibodies that are given. And when these are given to patients within 7 days of infection, they will go and neutralize the virus so that these patients will improve dramatically and not progress into a serious disease. And this is the concept of monoclonal antibodies.
Absolutely. And as I understand from what you just said, it is available abroad. Is this cocktail also available now in India, and by what name, sir?
Yeah.
And by which company?
Yeah. So this cocktail it's available in US. Two companies were making it, the Roche and Eli Lilly. In India, the so-called Regeneron is the one which is available in India. It's being marketed by Cipla. It's marketed by Cipla. The emergency use authorization was given by FDA to Roche company for Regeneron about 2 weeks back in beginning of May. But now Indian government has given emergency, the DCGI, the Director Control of the Drug Control of India has given emergency use permission to India also. So the Cipla company has actually imported this from Roche and is now available easily in our country. It's available as 2 doses. That is, each patient has to get 600 milligrams of this, each of this monoclonal antibody put in normal saline, given over 1 hour period as outpatient treatment. And the cost is about 60,000 rupees for the patient. So you see, it's not very expensive. The same drug, Roche sells it for about $10,000 in US. It's in India, it's about 1/10 the cost. And this is thanks to our company. Cipla is now actually marketing it.
And it's given in the form of a drip.
It's given in a single dose in a form of a drip as an outpatient procedure. It's not even, we don't admit the patient. We give it as an outpatient. Patient is absorbed for 1 hour and then he's set.
So we are learning as we are researching, I guess. So we probably will come up with a lot more things. On that note, doctor, please explain. A lot of people who are saying that they have contracted the SARS-CoV-2 virus without going out anyway from the home. And there have been certain speculations that perhaps they got it from the sewage pipes or perhaps they got it from the water. How true is this, or what kind of a myth buster would you say to,
Yeah. So again, this is an important public health question. When SARS-CoV-2 initially came, we are not sure how this virus is transmitted. Initially, WHO and all the scientists thought it is transmitted by droplet infection. That is, when I'm talking, sneezing, or coughing, droplets fall on the surface. I touch the surface. Somebody else touches the surface, touches their mouth or nose, this is transmitted. But we came to realize that this is not the main mode of infection. The main mode of transmission of this infection is through aerosol. Aerosol means that particles less than 5 microns, travel in the air. And when you sneeze, you talk, or when you're coughing, these particles travel in the air for up to 9 feet. And then they drop down after 9 feet. So if you are in the vicinity of a person who is infected, you're in the vicinity of 9 feet, the chance of this infection coming to you from this person is very high, especially if you're not wearing a mask or he is not wearing a mask. So this is aerosol infection. One of the wrong concepts people have is that it travels in air from place to place. It doesn't happen. In a closed room or an air-conditioned room, everything is closed. If there's a large group of people, this aerosol can stay in the air even up to 3 hours. So if you are in a room which is closed, an infected person was there in the room, he has coughed or sneezed, the particles can be in the air, and if you enter the room without a mask, you can get this infection by inhalation. It doesn't come through sewage, it doesn't come through water, it doesn't come through food. Actually, initially there was doubt that it comes through newspapers or it doesn't come through all this. It comes only as an aerosol from person to person, or a person who has set out this virus into a room which is enclosed. That's the reason why we are now advocating that if you have a bedroom, open your windows. If there's free ventilation, this virus goes up, it doesn't stay. But it doesn't transmit from one house to another house. People should not mistake. My neighbor has got it, so I got it. Doesn't happen that way. Unless you are in the same room as the neighbor. then the chance is there. But in the same flats, for example, you can transmit if you share a common air conditioning system and so on. Otherwise, it doesn't transmit across the houses.
Absolutely. So the answer is ventilate, ventilate, and ventilate, like you just said. So it cannot jump houses. Doctor, I'd like to understand from you, Dr. Reddy, about the gastro cases that are coming your way in the SARS-CoV-2 with SARS-CoV-2 symptoms, as people have been complaining of diarrhea, of acute vomiting, of such like symptoms. So, are you seeing those kind of patients in your hospitals there? And what is the general analysis that you feel you must share today?
Yeah. So thank you. Actually, ours is a predominantly gastroenterology hospital, so we see large number of these patients with gastrointestinal symptoms. There are actually three gastrointestinal symptoms that these patients come with. They come with diarrhea, they come with nausea, they come with abdominal pain. So diarrhea, nausea, and vomiting and abdominal pain are three predominant gastrointestinal symptoms. In terms of percentage of patients having the symptoms, in the first wave, we used to see more patients having gastro symptoms. In the second wave, we are seeing less patients with gastro symptoms because the virus has now undergone mutation and it has changed its clinical characteristics a little. Now, what percentage of people have gastro symptoms? We have found that about overall one-third of patients with COVID have gastrointestinal symptoms. About 10% will have diarrhea, 10% will have nausea and vomiting, and another 10% have other GI problems like liver problems. So about one-third. These symptoms can occur in the beginning of COVID, that is, even before they develop fever, sometimes they have diarrhea. For 2 or 3 days, they don't realize. In fact, we had a very prominent doctor in the region who just had diarrhea, nothing else. And he became very sick. And then we realized it was because of COVID and had to treat it. So sometimes they come just with diarrhea. Sometimes they have just nausea and vomiting and then develop the actual disease. Or they can develop the disease and later on, after 1 or 2 days, develop all these gastrointestinal symptoms. But more than is very important is liver involvement. This virus can also involve the liver and the pancreas. So we are seeing patients coming with acute liver infections, coming with acute hepatitis. More common, majority of these people, when you actually test the liver function tests, the liver function tests are abnormal. About 30% of them we are demonstrating their publicities showing abnormal liver function tests. So the problem here is some of the drugs that we use, like remdesivir, can also be producing liver function abnormalities, so you have to be very careful with these patients. The third area of gastrointestinal tract where it affects the virus is in pancreas. And this is important because not only can it produce acute inflammation of pancreas called acute pancreatitis. These patients come with severe abdominal pain, swelling in their abdomen, and when we check, the pancreas is completely closed. But also, this virus has a special affinity to attach itself to the islet cells, which actually produces insulin in the pancreas. So when it attaches to these islet cells, the insulin production decreases, and people's blood sugar becomes very high. So those who are non-diabetics can become diabetics, and those who are already diabetics lose control of the blood sugar. So this is what we have seen because of the pancreas being attacked by the virus. Very rarely, the large intestine is attacked, producing what's called colitis, so they can have blood in their stools. These are all the wide spectrum of gastrointestinal manifestations, which can affect about 30% of people. So it's a very important problem. Just like lungs, the second important organ affected by this virus is gastric.
So, another facet of the SARS-CoV-2 now that we are seeing, which is rolling out, is the fungus group, the black, white, and yellow. And this morning, there is another fungus being talked about. So, I'm sure, with all consideration for all the doctors who must be watching with trepidation every day a new fungus comes out. How would you like to explain black fungus and white fungus and what precautions need to be taken by people to avoid any kind of fungus related diseases, sir?
Yeah. So this is again a very important commonly coming up question now. First of all, I think we should not categorize these fungal infections as black, white, or yellow because that gives a different picture. The so-called black fungus is actually mucormycosis, and when it grows in the cultures, it's actually white with black spots on it. That gives a wrong impression. The reason why it's called black fungus is that when this virus attacks the body, it blocks the blood vessels. So when it blocks the blood vessels, there's an ischemic necrosis. The scar that comes out looks black, and that's why it's called black fungus. Actually, it's not black. Similarly, so-called white fungus is candidiasis because it causes a white coating on the tongue and so on, so it's called the white fungus. And similarly, we have aspergillosis also, which is also called again the white yellow fungus. So different names, but basically these are the three important types of fungus which are being seen in the COVID era. This is the mucormycosis, aspergillosis, and candidiasis. Of all this, mucormycosis is has the highest mortality rate and can be quite ghastly. That's why it brought attention to this problem. Now, there's something very peculiar about this virus. Is this virus normally resides in a lot of us normally. Actually, if you take swabs from the nose or from the mouth, you can find mucormycosis, but it stays as in a symbiotic relationship, doesn't cause any harm to the body. But for some reason, if the body's immune system is suppressed, or if the patients have diabetes mellitus, especially with ketoacidosis, a complication of diabetes, this virus then becomes very aggressive. It goes and attaches to the cells in the nose, eats off the nose and nasal cells, goes to the bone, goes into the eye, causes damage to the eye. It's called orbital, and then finally from the eye it goes into the brain. So this is called rhino-orbitocerebral disease. So it attacks the nose, eyes, and the brain. So it can also really attack the lungs. We're seeing less of the lung mucormycosis, just starting to see it now. Now, why is it occurring now? Normally, in our institute, we used to see one case a year of mucormycosis, usually in immunosuppressed people who have organ transplantation or on immunosuppressed drugs of cancer. We used to see them rarely. But now, why is it that every day we are seeing 4 or 5 cases, especially our ENT department is seeing large number of these cases? The reason is, unfortunately, many of these patients with COVID have already taken large dose of steroids, so that has suppressed their immunity. In addition to this, they are diabetic, and the diabetic control is not good. So steroids, lack of good diabetic control, and unhygienic intake of oxygen and so on. So you see now oxygen availability becomes difficult. So all sorts of oxygen will come into patient. So all this combination together, and also some antibiotics are used recreationally. Together, this virus has cropped up now. We are seeing quite a lot of these virus now, especially mucormycosis. And the problem with this virus is that once it enters the body in this invasive way, attacks the blood vessels, enters, it creeps like a small monster and it's very difficult to get rid of it. Usually, a surgical debridement, they have to remove that part. Sometimes eyeballs have to be removed. Sometimes part of the brain has to be removed. And a very expensive drug called amphotericin B has to be used. So it's a very devastating disease. That's why it's got attention. And I think, fortunately for us, I think once this second wave comes down, this disease also will come down. But this is a very important lesson in us here. The important lesson is two. One is not to use steroids indiscriminately. I want to emphasize this. Steroids are being unnecessarily used for this virus infection. We should not use steroids indiscriminately. Only when it's strongly indicated in the second week of the disease, in the right doses it will be used. I urge all the public not to go to medical shops and just take steroids themselves or just take some prescriptions for somebody and take steroids. Do not take steroids are the most dangerous thing. And second important lesson is that if you have diabetes, you have to keep it under good control. Follow healthy habits, exercise and so on, so that diabetes is controlled, so that you should not look upon a time when diabetes suddenly becomes rampant and you can't control it. So these are the two important lessons we have learned from this online.
Yes, sir. And as you said, good hygiene also to be coupled with all these practices. Steroids are strict no-no. Here, I'd like to ask you again that WHO has expressed a little doubt over the use of remdesivir and plasma therapy. Please share your thoughts.
Yeah. So a lot of drug treatment in um, patients with the COVID-19 has become controversial for several reasons. Now, coming first to convalescence plasma therapy, this was based on a trial called the recovery trial and also a trial which ICMR has conducted, which showed that use of convalescence plasma is not beneficial in patients with COVID-19. Now, my take is a little different from this. I'm not suggesting that this study is not right. This study may be right, and the ICMR or the Ministry of Health is right in advocating that we should not unnecessarily use the plasma. My take is that plasma is useful if used in the right way. Now, for a background on this, there have been several papers which have been published. The largest series has been from Mayo Clinic, which found that convalescent plasma is useful. Then there's the randomized trial which came in New England Journal, one trial from US and one trial from China having contradictory effect. One trial showing efficacy, one trial not showing efficacy. So why all these controversies? Why did recovery trial not show efficacy? The reason is that when you're using convalescent plasma, there's several things that have to be kept in mind if you have to use it carefully. You have to use this within 5 days. So if you use it after 5 days of the symptoms, is not going to be useful because it's only to protect the virus. Similarly, like monoclonal antibodies, you have to use it very early on. So that's why plasma therapy is effective only very early on. Number one. Number two, convalescent plasma, when it's used, you should actually check the neutralizing antibody in the plasma. None of the studies have done this unless you have a very high neutralizing antibody levels. In our unit, in our institute, for example, if you have more than 250 units of neutralizing antibodies against the spike protein, and then use this plasma very early on, we found it to be effective. So I would say personally that although recommendation currently from WHO and from the Ministry of Health is that convalescent plasma is not recommended as a standard therapy, I think we have to revisit this carefully, have a look at the timing and the quality of plasma before it's used. Of course, fortunately, monoclonal antibodies will overcome some of these effects, but still, plasma is cheaper and it's available more freely. And if you really relook that, in fact, I would suggest also to the Ministry of Health to conduct a nice study which takes into factor these two factors: early use and high level of neutralizing antibodies. Only then we can discard it. I don't think we just do it off right now. The second, remdesivir again has been controversial. Again, recovery study showed that remdesivir is not useful. Again, the problem with remdesivir is that most of these studies, especially the Western studies, it has been used late in the patients. It has been used in patients who are on oxygen in the second week, along with steroids and so on. In those cases, remdesivir is not useful. I would strongly suggest don't use remdesivir in the second week of disease. Remdesivir should be used in the first week, and there is a very famous trial in New England Journal which showed if the remdesivir is used in mild to moderate cases in the first week appropriately, then it definitely decreases the duration of illness and virus shedding. So I think there is still a role for remdesivir in the first week, and it has to be used very early before the patient goes into the second week where it's actually cytokine storm and not viremia. The reason is remdesivir is an antiviral drug. The virus causes damage only in the first week when it's entering into the body. After the first week, the damage is caused not by the virus but by the cytokine storm that occurs because the virus is fighting the immune system of the body. At that time, the remdesivir is not going to be useful at all. Use it in the first week when the virus is trying to enter into the body. So I think there is again this another drug you should not throw away. You should look at it carefully, revisit it.
There is a report that I read this morning. It's a WhatsApp forward actually about the third wave being very, very dangerous. A study by IIT Delhi, sir. And the court has also directed, I'm sure you've seen that study. What do you feel could happen in the third wave, and what is the science of it telling us that why it would attack children?
So the prediction of this second, third, or fourth wave is actually very not very scientific. It's all modelings that are done. The best people who can predict is astrologers. They can tell us whether it's happen or not. But otherwise, scientifically, it's not so easy to prove because the reason is there's going to be a lot of variability factors happening. Now, what is going to be the variability factor? If, for example, from tomorrow onwards, all the people are going to go into COVID appropriate behavior, right? Or if vaccines are going to come out in a large way from July onwards, and in 3 months' time, using 1 crore vaccines per day, we can vaccinate 90 crore population. Then the third wave can be aborted completely. But other way around, if people say, okay, second wave is gone, let us be free, they do COVID inappropriate behavior, and the vaccines don't come, we don't take the vaccine, then a third wave will definitely come somewhere in the end of the year. So this depends upon how we behave and how we can prevent it. If you look historically at what happens in Spanish flu and other
Yes.
flus that have come, all of them have first, second, third, and usually fourth wave before it dies down, before herd immunity comes. The second wave one is the one which is the highest, which has the maximum mortality morbidity. The third wave is a little less, and fourth wave is actually very less, mild pockets occur. So this could be expected. Only thing is the first time in the history of mankind, we have a technique to prevent this from occurring, from prevent this natural history, and that is a vaccine. If the vaccine can be given in a real massive way to a population, we can prevent this stuff.
Uh, 30-second response from you, doctor, on how some doctors are indiscriminately prescribing blood count, D-dimer, CRP, and even CT scans.
Yeah. So quickly, these are inflammatory marks. For example, D-dimer will give an indication whether you should use blood thinners or not. IL-6 is an inflammatory marker saying that whether the body is having cytokine storm or not. As you said, these are being unnecessarily overused. The main use of this is at the end of the first week. We want to know whether the cytokine storm, whether anticoagulants is required or not. We use it once, and then maybe at the end of the treatment, we can use it to monitor whether the treatment is effective. So most of the patients, even with severe disease, may require it twice. So unnecessarily overuse is not going to be helpful in terms of monitoring the disease. But right, like you rightly said, it's being overused because patients are very anxious. They want something to be done.
Absolutely. What would be your advice to lactating mothers and pregnant women now? Should they go in for the vaccine? What is your take? What are your thoughts of that, sir?
So regarding lactating mothers, there's no question. They have to go for vaccine. Several studies have shown that the vaccine is not only beneficial for them, but the antibodies that come can go through the breast milk is beneficial to the child also. So lactating mothers definitely yes. Now what about pregnant women? Pregnant women, this is a little controversial. The Indian Society of Obstetrics and Gynecology have asked the Ministry of Health for permission to use it in pregnant women because the study in US showed that when it's given to pregnant women, over 90,000 women, it has been safe. And but unfortunately, that was mRNA virus. We don't have large number of studies using the current vaccines that we're using in India, both Covaxin and Covishield. So we're still getting the data now. It looks like it is safe, but right now the recommendation from the Ministry of Health is not to use it in pregnant women. Whereas maybe if you have access to mRNA vaccine, you can use it safely. For the rest of the two vaccines from India, we're still getting the data, and we'll know probably in a few months what we can do.
One last question before we leave, Doctor. I'd like to ask you as to the statistics of vaccinations in your state. Are you satisfied? Do you think it could be ramped up further? What are the vaccines you're looking at among the various plethora of vaccines that we would be having now, whether it is Sputnik, Covaxin, Covishield, Zydus, Cadila, Johnson & Johnson? What is it?
Yeah. So, of course, one can never be satisfied with vaccination anywhere in the country. One of the reasons, of course, is the vaccine inadequacy that we have. We're not having adequate stocks. I think it's important to remember that vaccine manufacturing is a complex issue. People say, why can't we ramp up? We can't ramp up like that. The vaccine cannot be ramped up immediately within 1 week, 10 days or something. It's a huge involvement of industry, the government, science, and so on. So it will take some time. So we cannot blame anybody for this. Ours is a very large country. If you look at the number of vaccinations that have been done in our country, it's more than many European countries. I mean, whole country has been vaccinated. European countries in numbers. So we can't. The problem is our population is so large, and vaccines have been produced in a massive way. So I think the two current manufacturers are trying to ramp up. But fortunately, we're getting Sputnik also, which is going to come somewhere from in next week, 10 days time, we're going to get Sputnik, which is going to be manufactured by 2 or 3 manufacturers in our country. So the numbers of vaccine will increase. Similarly, Johnson & Johnson has tied up with biological devices. They're going to start manufacturing. We have 2 other protein subunit vaccines which are already tied up with international companies manufactured in India. And then, of course, we have our own indigenous Zydus DNA vaccine, and in a few months' time, the mRNA vaccine. All these are coming. So by July 1st or first week of July, I believe we'll be more than self-sufficient in vaccines. My belief is that if you can vaccinate 1 crore populations per day in India, then we can very quickly, within 3 months' time, get herd immunity and conquer the disease. So hopefully, everybody working together, the vaccine manufacturers, the industry, the government, the scientists all together, will be able to ramp up this vaccine production. Right now, our vaccine production is at a level of about 8 crores a month, which is grossly inadequate. We have to go to at least 3 times or 4 times this production, and hopefully by July this will occur. I think everybody is making effort for this to occur, and then we can see very good action. Second aspect of vaccine, again, I want to emphasize here very importantly, vaccine hesitancy should go up. Everybody should opt for these vaccines. They're very safe. They're no side effective. 80% are protective. People telling, I took vaccine, I got COVID. If you take vaccine, between the first and second dose, you can still get disease. Or after the second dose, you get disease, but usually it's very mild. You don't get a serious disease. So this vaccine is not only to prevent the disease, but it prevents mild disease from becoming serious disease. So kindly take this vaccine. Everybody must propagate this vaccine. And through your channel, Nidhi, I would suggest that all of us should become proactive regarding vaccine.
Absolutely, and on that absolutely pragmatic note, I'd like to thank you for joining us today. And with this, viewers, this is a wrap on this week's FAQ. We look forward to having more of you, Dr. Reddy, on our programs. Thank you so much for joining us. Namaste.
Namaste. Thank you very much.